Today we're going to talk about a new procedure for patients that have severe end-stage COPD. And as you guys know, we've been doing lung volume reduction surgeries since the 1940s in this country. It was a fairly successful surgery if you survived. There was a high recovery rate, but the mortality rate immediately post-procedure was very high, and the morbidity rate was even higher. So they had extended stays in the hospital, extended air leaks. So for years, people have been trying to come up with a less invasive alternative. And now we have a new procedure that's been approved by the FDA where we utilize one-way endobronchial valves where you can exhale but you can't inhale, and we collapse the lungs. There are several advantages to this, and we'll go through that today. It's a much less invasive process than the original lung volume reduction surgery. The other thing about it that's improved is that those were particularly only for the upper lobes. They didn't tend to do lower lobe lung volume reduction, and a lot of those studies didn't support that. With the endobronchial valves, you can do either the upper or the lower lobes, which is an advantage. Okay, this is an innovative technology. We all have severe end-stage COPD patients who have minimal choices and little options in regards to what they do. We all know that in Oklahoma, this is a significant problem. There's an 18% higher incidence than the national average for COPD. Per capita, Oklahoma is number 4 in the United States in nicotine addiction behind 3 tobacco row states. So, as usual in Oklahoma, we lead the nation in things that we want to be last in, and we're last in things we want to be first in. So, this is a tremendous problem and also a tremendous opportunity for us to provide these patients with better care. I'm going to talk about 2 types of endobronchial valves, the Zephyr valve and the spiration valve. This talk is free of bias with either company. I have my own personal bias. I use one valve and not the other because I think it works better, but I'm not being paid to say that. We'll look at the key data from multiple trials, and importantly for this audience, I think, which patients are eligible and how do you do that? I'm not going to spend a lot of time on this because I think most people understand emphysema. We'll go into more detail on air trapping, and we all know it's a progressive disease, and we've all seen those patients gradually decline before our eyes. I do like the pictures. I'm a picture learner, I guess. I love the pictures of the lung tissues, healthy lung versus emphysematous lung. And you can see the alveoli versus the blebs and the bullae. I don't believe that this prediction that $49 billion in direct medical costs in 2020 is accurate with COVID. I do believe that it will likely be compensated for in the next 2 to 3 years. I think a lot of these people have been delayed in their therapies, and so I think there will be a rebound effect, if you will. So I will make a point on that slide. Prognosis and quality of life are worse with COPD than lung cancer. I'm not as convinced about the prognosis, but I know the quality of life is likely to be worse because you can't breathe, you struggle to breathe every day for years. That's a tough daily process. This is an interesting slide. Hyperinflation is a key driver of symptoms and mortality, I think it's important to note mortality. What this graph shows is that you have mortality versus or cumulative survival versus months on the bars, and they're looking at inspiratory capacity and total lung capacity as a marker. And you see as hyperinflation increases, your inspiratory capacity to TLC decreases and your mortality goes up. These people have higher baseline dyspnea, and if you can't breathe at rest, you can't tolerate exercise. That's fairly straightforward. Have low peak oxygen uptake, they have lower daily activity levels, and the next one's important to me, low BMI and/or muscle strength. These people have cachexia pulmonary disease. And when they start losing weight, that's a very poor prognostic sign. And importantly as well is the non-pulmonary effects. Cardiac and circulatory function are also negatively impacted. I like these x-rays. I love x-rays anyway, but and you can see on the left a healthy normal lung, or on my left I should say, and on the right you can see a hyperinflated emphysematous lung. I won't belabor this point, but I like to show that. This is another slide that shows disease progression in a stair-step type fashion. Initially hyperinflation, then decreased activity, all the way to increased mortality, just kind of reiterating the point. Spectrum of treatment options. This has been a significant limitation for COPD. We haven't had a lot of good therapies. I mean, basically you get inhalers, maybe pulmonary rehab, and you went to transplant. Some people got lung volume reduction surgeries, but that was a very narrow pool of people. And now we have a lung volume reduction that opens it up to a larger pool of people. This is a Zephyr valve. They're tiny. They look like the Apollo lunar modules to me. They're small. We put them in the bronchi. You get similar benefits to surgical lung volume reduction without incisions. Most important thing, I tell people this frequently, it's much more difficult to work these people up and decide if they need valves and to treat them after they get them than it is to do the procedure. Procedure's not, in my opinion, that complicated. It's fairly straightforward. Precise patient selection is critically important. Obviously, you don't want to expose a severe COPD patient to a procedure unless they're going to have a perceived benefit. And the last point is incredibly important to me. These are removable. Let's say you make a mistake. You select a patient and it doesn't work. You can go back in and take the valves out, and they're back where they were. I think that's one of the biggest benefits of this is the reversibility. So you can see this is the same spectrum of treatment options. They just put valves in there. Inspiration is a valve I'll talk about too, and you can include that in these valves. Okay. I'm going to show you a video here if I can. See if it works. It shows you how the valves work, and in exhalation, it's open like that. I call it guppy breathing because the end of that valve looks like a guppy breathing to me when it opens and closes. Hold on, let me see. Oh, forget it. This shows the benefits of valves. Starts with successful occlusion of a lobe. There's reduced hyperinflation, reduced air trapping, lung function improves, dyspnea improves, and most importantly to me, quality of life improves. All of these things are well and good, but if the patient doesn't feel better, it's not that meaningful. I will tell you that people with severe emphysema are desperate for something. I will tell you that the hardest talk I have with patients who come for this procedure is the talk I have when I tell them that they're not a candidate. They don't fit the criteria. And I actually think, in what I've seen, that the numbers are higher than these graphs show in regards to the incentive for patients and the desperation that they have. This is a spiration valve system. It's another alternative for valve placement. Has some different studies. They looked at them a little bit differently. There are some patients that will fit the spiration that won't fit Zephyr, and vice versa. And we'll get into that a little bit. These 4 white devices to the right are the devices that they lock the valve in and you release, and you can see there's numbers 5, 6, 7, and 9. Those are the sizes of the valve, and they get bigger as they go up. It looks like a jellyfish to me, and it has a little pin that you can grasp and remove, but that pin's difficult to grasp sometimes. It also looks like an umbrella. It kind of, when you deploy it, it kind of expands and occludes the airway that way. We utilize a quantitative CT analysis for both valves. This is the spiration evaluation of that, and they look at emphysema severity, they look at fissure completeness and heterogeneity. Now, the important things there are emphysema severity, and it's really important in regards to fissure completeness. If you don't have completely occluding fissures, you have collateral airflow and they don't work. Emphysema severity has to be greater than equal to 40%. Fissure completeness, it has to be 90% on the spiration valve. And there has to be a 10% difference in blebs between the upper and lower lobes. This is how it's placed and how it works. You put these valves in the bronchus and occlude like everyone else. It diverts airflow, and you can exhale around the valve, so it works in a similar manner. With either of these valves, they both require multiple valves in a lobe. This was the improved study associated with spiration. They had 172 patients. They randomized in a 2-to-1 fashion. Alpha-1 antitrypsin deficiency was excluded from the randomization. They put valves in all their alpha-1 patients. And they measured multiple primary and secondary endpoints. They showed an improved quality of life, decreased hyperinflation of 6.3%, volume reduction of the target lobe of about 50%, which I'm not sure that's enough, and that's one of the reasons why I don't use that valve. I think you need more occlusion and better reduction of volume in those lungs. It has a risk to benefit ratio that it is safer than a Zephyr valve. We have less complications with the spiration. And it also has improved lung function with an improvement of about 12% in the FEV1. Now, when you look at that number sounds impressive, but you have to remember that these patients' FEV1s are so low that we're not talking about huge changes in volume. Right now we're going to look at clinical data, and I'm not going to belabor these points. I'm not going to spend a lot of time on that, but we will go through it. I actually did the research in the NET trials years ago for endobronchial valves. Subsequently, they did the Believer trial, and the thing that was most important in that was identifying the fissures and understanding that there were incomplete fissures. When we initially started, everyone felt like fissures were always complete and there was no collateral flow. Obviously, that turned out to be completely untrue. The Stelvio trial is important because it not only looked at heterogeneous bullous emphysema, but also homogeneous. And if your upper lobe and your lower lobe had the same amount of damage, you could still get improvements. And then the last trial was the Liberate trial. These are the clinical benefits: upper and lower lobe treatment, heterogeneous and homogeneous emphysema. And probably the most important advantage, in my opinion, to the Zephyr valve is collateral ventilation status utilizing the Chartis system, where you occlude the airway and it confirms what the CT scan said in regards to fissure completeness. I'm not going to go through this. This is an important slide right here. It shows how collateral ventilation works. And on your right, my left, no collateral ventilation in green, that's CV negative. And the outside lung shows collateral ventilation, that's CV positive. If a patient's CV positive, it's been my experience that valves don't work. And those are the people that get excluded. This is the Chartis system. It's actually fairly simple. It simulates treatment in the sense that you occlude an airway with a balloon, a lobe, and it measures both your airflow rate and your pressure, and if they both decrease to zero over the course of time, it means that you have completeness and you don't have collateral airflow. This is another cartoon drawing of how the balloon works, and to the side you see the Chartis system, and when you see that trending down to zero, as you see in the top slide, that's a complete fissure. In the bottom, where it doesn't move, that means you have collateral flow. I'm going to skip these studies for time's sake. If you guys have questions about them, I'll answer them. The Liberate study was important. 190 severe. They used heterogeneous emphysema subjects with no collateral ventilation, so they did Chartis before they put them in. 2-to-1 Zephyr to standard of care. They did randomized controlled trial, and they did 12-month follow-up in both treatment and control arms. It's always interesting to do a sham bronchoscopy. And you can see the results. The Zephyr valve, almost 50% of subjects showed a baseline change of more than 15% in their FEV1. Now, interestingly to me, in your placebo group, there was still 15%, 16% that showed an improvement. So clearly we don't understand all the mechanisms yet, because those people didn't get valves. And if you look at all the rest of the endpoints, they significantly improved in comparison to standard of care. This is another slide that looks at responder rates in regards to multiple different indices, quality of life scores, dyspnea scales, residual volumes, 6-minute walk distance, total lung volume reduction of approximately 350 cc's, which is significant. And it was this study that got the valves approved by the FDA. Now, this is important. These are the risks and the side effects. This procedure isn't free. There is about a 20 to 25% incidence of pneumothorax. It has complicated our treatment of pneumothorax immensely because, especially in the upper lobes, there is pneumothorax ex vacuo, where the right answer is not necessarily a chest tube. You go back in and remove a valve and it re-expands the lung. Because what happens is the upper lobe collapses so rapidly, the rest of the lung does not have an opportunity to expand around it. So it creates basically a vacuum in a space. And if you put chest tubes in those patients, the morbidity and mortality of that go up significantly. So, pneumos have always been fairly straightforward, but not in this case, and it becomes incredibly complicated when you become a referral center and these people go back to their hometown and they go in the ER. And so what we've started doing is providing our patients with a card to tell them to call us so that we can run through it before they put a chest tube in. I think that's really important. There's also a significant incidence of pneumonia, and obviously we're putting a scope in the airway, so you have to worry about COPD exacerbation. The biggest issue we've had is pneumothorax. Some people have exacerbated, but they've been manageable so far. And we have had, of course, I got the interesting patient who developed a pneumonia in the lung opposite where I put valves, which created a real dilemma because all of a sudden he didn't have enough alveolar volume and he got hypercarbic respiratory failure. So I had to go back in and remove his valves so that his right lung could compensate for his left lung pneumonia. And that was a hard day, making those decisions because no one knew what the answer was. All my friends I called across the country, they didn't know. They hadn't seen it. Pneumothoraces occur within 72 hours of the procedure. This is also important because when the FDA approved the procedure, they approved it with the caveat that you have to be admitted for 3 days to monitor for this process. So with spiration valves, you do not have to be admitted to the hospital. With Zephyr valves, you do have to be admitted to the hospital. So that's one of the differences in the two. The spiration reps will tell you that's because they collapse the lung slower. My bias is that's because it doesn't collapse as well. And so you have to determine what's best for your patient. These are all straightforward, and basically we've covered that. This has been accepted well globally, and it's been approved in Europe for several years before it was approved here in the U.S. The GOLD criteria, which is probably the best criteria for COPD in the world, gave it a level A for evidence, which impressed me. UK has the National Institute for Care and Excellence. They approved it. And it's also been supported by the Germans and the Dutch. Now, the important stuff, which patients are eligible. And there are eligibility differences between the spiration valves and the Zephyr valves, and we've touched on those. Obviously, you have to have COPD to get it, kind of straightforward. The second one's really important. They cannot smoke. You can't do valves on patients who continue to smoke. Too much risk for pneumonia and side effects and complications, and it's just not feasible. FEV1 is anywhere from 15 to 45%, and they're short of breath despite optimal medical management, which is kind of a vague, nebulous thing. To the side, there is a MRC dyspnea score, which we utilize to determine that. How to send for a referral. Identify, this is easy to me. I'm not going through all this slide. You can identify candidates and you can call us and we'll evaluate them. Right now, Integris was doing this and they had a significant number of patients, but both of their transplant pulmonologists left, and so that they're looking to hire people and they haven't gotten it done yet. There's a physician at OU's that's doing them, but he's only done one and is interrupted with COVID. And so there's not a lot of options right now in the state. Hopefully that will get better, because I think that this is going to be a tremendously popular procedure that more and more physicians are going to want to participate in. Once you make the connection with the local treating center, then you can follow up with referral. In our clinic, I promise you, we will notify you and let you know what we find, and we will call you back if they get valves and tell you how they did. There's a mylungsmylife.com website where you can find treating physicians. These are the things that you have to do, inclusion, exclusion criteria, I call them. Medical history, emphysema, BMI of less than 35 kilos, that's important. They have to be clinically stable on less than 20 milligrams of prednisone a day. Non-smoking. 6-minute walk has to be between 100 and 500 meters. PFTs, post-bronchodilator, FEV1 15 to 45%. RV greater than 175%. Total lung capacity 100%. For an RV greater than 200% for heterogeneous emphysema, TLC greater than or equal to 100% for homogeneous emphysema. Then you do the usual, collect blood gases, and we do a high resolution CT that we use as a staging procedure, which, by the way, I just got on the phone and had to do a peer-to-peer 20 minutes before I came out here. The Blue Cross Blue Shield of Oklahoma has approved the procedure for COPD patients, but apparently haven't gotten the memo on the workup. So, and they also need an echocardiogram. So, clinical workup is number one. Stratix is a report that where you utilize the surgical planning CT scan, you take a disc, you send it off, and what it gives you is the volume in each lobe. It also gives you the destruction by emphysema and fissure completeness. So it's the most important screening test. If the fissure completeness on the Stratix is 95% or less, I always do Chartis, and I frequently do Chartis on people that are higher because I've been full. So I tend to do steps 2 and 3 on almost everyone. The valves, Zephyr, Spiration, either one, include the target lobe, and they're admitted for at least 3 days. Now, I've had complications, and I can tell you the complications when they occur, they're difficult to manage. Sometimes they're prolonged. I've had these people in the ICU, I've had them intubated. Fortunately, I've gotten them all extubated, which I thought was a little bit scary a few times. And so far, I'll keep my fingers crossed, but no one has died. At least my experience. I'm not going to talk about reimbursement. I will say that hasn't been a significant issue. Medicare pays for this, and a significant proportion of these patients are Medicare. Blue Cross pays for it. The others are doing it on a case-by-case basis, but it hasn't been particularly difficult. So I'll open it up for questions. Yes, ma'am.
This is from one of the online folks. Can you explain exactly what is fissure completeness? What are you saying? Can you just describe
Oh,
that?
sure, I'll be happy
Explain
to. The fissures are between each lobe of the lung. So there's a major fissure for the right upper lobe, a minor fissure for the right middle lobe. And on the left, there's one major fissure differentiating left upper lobe and left lower lobe. So that separation of those lobes has to be complete. That's actually a very good question because it gets, we talk this stuff all the day and that gets lost in the wash. Yeah, that's a good question. How do you decide which lung to do? Which lobe? I look at multiple factors. One of the factors I look at is the damage between lobes. Let's say, for example, you have 65% in the upper lobe of damage, bullous emphysema, 40% in the lower lobe. Your fissures, also what I look at, and let's say it's 92% complete, okay? Then you go to the other lobe, and it's 63% in the upper lobe and 47% in the lower lobe, for instance, but your fissure is 97% complete. I would do that lung, even though the damage is not as significant, because you're much more likely to get atelectasis because of the completeness of the fissure. I believe the completeness of the fissure is the most important thing. And that's the same as this question, fissure completeness and collateral ventilation is what we're... Now, I will say in Europe, they're doing studies. This is actually really interesting. They're doing studies to seal the fissures and make them all 100%. And it's early, and I don't know how far that trial has come, but it intrigues me. I think it's probably a next step. I don't know. I haven't even seen an abstract on it, so I'm not sure. I know that they're participating in the trial. I just don't know where they are. I like to do it before. It takes a while to work these people up. They're going to do better with your procedure before, and, if I had unlimited funds, I'd do it before and after. I think it's a critical piece to the puzzle. Pulmonary rehab is very important.
Is the incomplete fissure, is that part of the disease process, or is that just different lungs?
Suspect it's genetics. Like I said, when we first started doing these studies, 10, 15 years ago, people just intuitively thought the fissures were complete. And then we'd put valves in all these people, and some would collapse and some wouldn't. And you're like, well, what happened? That's how we found out that they weren't complete. And that's how we found out also that it was really, really important if you wanted to do this. You don't have to worry about fissure completeness when you're doing surgery, because you're taking it out, it's gone. But for this, it makes a big difference. Yes, ma'am.
Another online question is, if fissure completeness between the lungs is the same, do you then do the worst lung damage-wise first?
Absolutely. Absolutely. We factor both of those things on every patient. And, one thing about medicine that you guys all know is you don't want to get into tunnels. You don't want to get tunnel vision and not look at everything. They don't have enough lung function. You know, I saw a lady in the office this week that had a true lung volume reduction surgery in 2004, and they took both of her upper lobes. But most of these people, if we did that, they would be respiratory cripples or have hypercarbic failure. They just don't have enough good lung tissue for that to be viable. I get that question a lot from patients. Okay, I really feel good, this worked. When are you going to do my other one? Never. Thank y'all for having me.
Thank you, Dr. Boomer.